Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, dear respected viewers, ladies and gentlemen. Hello and welcome. Dr. Mohammed AlSheef, your host of Elixir of Life from Saudi TV Channel 2, is kicking off another inspiring and informative episode with our distinguished guest, Dr. Nuha AlSaleh, to talk about very important topic, breast cancer. Besides that, we have other important segment. Stay tuned for a special episode. Now, welcome back to Elixir of Life. We'll go for the second segment. We'll be talking about the quote of the week. To watch more details, please stay with us. Once again, welcome back to Elixir of Life. Our next segment is the most important, our episode theme, breast cancer. Breast cancer is the most common cancer in women in Saudi Arabia and the second main cause of cancer death in women after lung cancer. Advances in screening and treatment have improved survival rates dramatically since 1989. Breast cancer is a disease characterized by abnormal cells that multiply uncontrollably, forming a tumor. If left untreated, it may eventually spread beyond the original tumor to other parts of the body, a process called metastasis. Breast cancer is a disease with many histological types and luckily detectable in early stages by screening and curable. That sends a signal with hope. It's my honor and pleasure to present my distinguished guest, Dr. Nuha AlSaleh. She is a breast and endocrine surgeon working at College of Medicine, King Saud University, as well as she has academic title, Assistant Professor of Medicine and Surgery. It's my great honor and pleasure. Welcome, Dr. Nuha.
Welcome. The honor is mine.
Okay. I think we have a quite interesting agenda to discuss. Without further ado, we'll start by first question, what's breast cancer in a nutshell?
Well, in the nutshell, breast cancer, from the name, it's a cancer disease or a malignant process. To simplify things, it's abnormal cell or abnormal production of the cell where it's becoming beyond the control of the body, affecting the breast organ. The breast, as you might know, we have two breasts, male and female, the same. Probably is much more prominent as it's well known in female, and it's drained everything in the axilla and the lymph node in the axilla, and that's probably why for tons of people doesn't know why we need to address the axilla and the breast, because it's basically linked together.
Beautiful, because drainage of the lymphatic drainage into axilla. Thank you, Dr. enlightening that. So for anatomical reasons, how we divide the breast is like, because we hear a quadrant, is it upper or lower, or does it make difference, or
Well, this is probably a medical terminology. What matter for the patient, if it's affecting the right side or the left side, that's what's the most important. Now, for medical people, we put an imaginary line making the breast in 4 quadrants, one in the middle, one transversely. Just for an interest, it's usually the most common site in the upper outer quadrant. The position of the cancer will affect the chances, whereas if we have a lymph node metastasis. To simplify things, it's basically is how much or how high is the chance, if depending on the location, the breast cancer will go to the lymph node. So the right or the upper quadrant, basically cancer, it's go earlier to the axillary because it's makes sense, it's nearby.
Okay, excellent. So it has a prognostic value.
Absolutely.
Doctor, just to now to move to the next important question, I would like you to know shed some light about how common is breast cancer internationally and locally.
Well, unfortunately, it's very common, and even to make things beyond that, in Saudi Arabia, for unknown reason, it's unfortunately more common than the international standard, and it's more aggressive in terms of presenting an earlier stage and a larger size comparing to the international standard. And that's probably what led to the intensive screening program initiated in the kingdom.
So is it true that breast cancer is the most common cancer among Saudi women?
Absolutely. In Saudi Arabia, yes, it's the most common cancer.
Excellent. And just to dig more, what do you think, from your extensive experience, the risk factors or causes of breast cancer generally and in our community?
Well, generally, if I would say number 1, number 2, and number 3, it's family history.
Family history.
That's basically the most important thing. So any lady who having a family history, regardless of the degree, I mean, the first degree is higher than the second or the third, but that would increase her risk. The other things, it's internationally standard, having an early menarche, which is to make things easier, having a period in earlier age. Excellent. And delayed menopause, basically having the prolonged period time. To simplify things, that the woman will be exposed to the hormone effect for a prolonged period. Mm-hmm. Nulliparity, which is in another word having no kids and no breastfeeding and no pregnancy, that increase the risk. But those are minor details. The most important things probably it's the family history.
What about smoking, diet, environment? Does it play a role?
Well, we'll put it out this way. I believe smoking, diet, and environment has been involved in every single cancer. Excellent. It's very difficult to pinpoint one thing and link it to the breast cancer per se. My general advice for my patients usually just go with the healthiest lifestyle. You could afford.
Excellent. And what about the oral hormonal therapy, like oral contraceptive pills? Does it increase the risk or protective or?
Thank you so much for this question, because it's a very common question. So oral contraceptive, the earlier one before the 1970s have a different combination. It's been shown during meta-analysis, which is a big data or big analyzing data for the audience, that it slightly increased the risk of breast cancer. However, the modern OCB, the modern oral contraceptive,
newer generations,
the newer generation doesn't have the link.
Okay, great. Because this has been, controversial question, but it was answered by, you mentioned meta-analysis, which is advanced study. What are the signs and symptoms of breast cancers, that can be discovered by the patient?
Okay, so there is an overt sign can be found by the patient, and there's a hidden sign, and that's the reason we initiate the screening program. So sometimes the breast cancer just could be a spot found in the mammogram or the ultrasound. That's the reason we initiate the screening program. Excellent. Even if the person does not have any symptoms.
Can you, doctor, while you are commenting on about the signs, okay?
Absolutely. So for the sign and symptoms, the patient herself will consider it alarming. I would say lump is the most common.
Lump, okay.
So if she felt a lump, if she thinks she have a change in her breast, she should seek medical attention. The second most important, I think, it's the nipple discharge, the bloody nipple discharge. Bloody nipple discharge could be early signs of breast cancer. So the woman have to be warned about the symptoms or sign and seek medical attention immediately. Definitely there is much more other signs like ulceration, change in the skin color, could go to more advanced one, what we call in medicine boudorange. It's basically the skin gonna look really thickened like the orange cover.
Yeah.
So
feeling,
so it's really an advanced size. Any change in the nipple usually, and we have to understand women have a different nipple shape, but the change for the same woman, it's really a warning sign.
Excellent. What about the symmetry between the two breasts? Is it one of the signs of breast cancer, if it is asymmetrical in the size or shape?
Well, there is a famous say, they are sisters, they are not twins.
Okay, great.
So
Excellent.
normally there is asymmetry. However, what I tell my patient, it's what's new for you. So if she's born with, or since she reached puberty, she have a mild asymmetry, that should be fine. But a sudden change in the size, that's another warning signs.
Excellent. So that's bloody discharge.
Yeah.
Excellent. And what's the importance of self-examination, okay, breast cancer?
Well, self-examination is being studied already, and it's never been proven that it can alter or change the detection of breast cancer. Having said so, I would recommend any woman to know her norm. You cannot really rely on self-examination because there's tons of factors could change the self-examination, like what time, how it's related to her period, diet effect, tons of things. So really cannot rely, but each woman have to know her norm, and then if she have abnormal, seek medical attention. But study-wise, never been proven to make any difference.
Yeah, I mean, like frequency-wise or age, one should be start, self-examination.
Well, basically, that there's the data that's not supported that can alter any prognosis. So what we basically ask any woman above the age of 25 just to know the norm of hair.
Excellent. And this is another picture. If there's any sign that you can highlight.
Yeah, so as you could see, the retraction, indentation of the nipple, any change in the nipple, whatever it is settled, should be noticed by the woman. Discharge from the nipple, it's a very important and probably the most missed sign.
Okay,
the woman
great.
will have it once, then she's kind of okay, we'll forget all about it, and probably this is one of the easily missed sign. Definitely change in the skin texture, lump is important.
Excellent. What do you mean retraction? Just can you explain it?
Basically, the nipple, as if we could look here, this is how's the nipple projecting. Now, this is one shape of how's nipple projecting. Women have a different projection and different shape. She have to know her norm, and the retraction, that's nipple gonna go inside.
Inside, okay.
But I would have put it out this way. If she's born with this inside kind of a nipple, that should be fine. And it may change with age, pregnancy status, breastfeeding status, but a new change is definitely an alarming one.
Excellent. Doctor, now we are coming, you highlighted very well the clinical features of breast cancer and early stages and the most important features. Now, coming to the next step, diagnosis. How we diagnose breast cancer?
Well, diagnose breast cancer, basically two main things.
Investigations.
Radiologically and having a pathological diagnosis.
Excellent.
In another word, we have to start with clinical examination.
Excellent.
Where there is some clinical suspicion. Sometimes the patient will, as I said, is going to come with a complaint, so I have to investigate it with ultrasound or mammogram. And to pinpoint something, the classical teaching we give in the medical student that ultrasound for people who's younger than 35 and mammogram for older than 35. However, in our specific community in the Gulf, not only in Saudi Arabia, sometimes we have to complement them, and for whatever it is the reason, we're still investigating that, women having a denser tissue. So probably mammogram would not be the best thing to screen them. So that's what made us sometimes asking for the two modalities to combine.
Excellent.
That's the second things. After doing radiologically, we usually complement it with some biopsy, taking a pathology. Biopsy, to simplify things, it's just I'm taking a very small piece of that area whose I think is diseased and examine it under the microscope and tell me the nature of that disease. It's usually having very high sensitivity and specificity, so it could tell me there is a disease or no, up to 95%, but as anything else in life, nothing 100%.
Very beautiful. So mammogram is most commonly used investigations. Like when you go outside, some campaigns, screening campaigns for breast cancer, what do you use inside, mammogram or ultrasound, or they have both? If you go outside and you have screening programs, sometimes you have the truck with mammogram. So they say mammogram. So this is a mammogram, doctor. I mean, could you, explain what's mammogram in layman terms?
So mammogram is a special X-ray to simplify it. Basically, it's examining that breast tissue. So any abnormality will look like a white patches, and depending on the pattern of this white patches will determine if it's a picture, it's look good or bad. What's probably most of our patients will say, so why is the mammogram is not working out for me? This is a special X-ray or able to penetrate the tissue. Sometimes the tissue is so thick so they cannot penetrate it, and that's basically what's very commonly happening in our Gulf area. So they will tell you the mammogram did not tell me anything, please go do an ultrasound, and that's the explanation.
Excellent. This ultrasound is for denser tissue, for younger, less than 35, if you highlight.
Yeah, but that's the crude rule. In our country, ultrasound has been working even in 50, 55 years, and I'm actually studying why we have just denser tissue.
Excellent. Just asking you a question that's relevant. What's the effect of implant on the mammogram? Because I hear that it can affect the quality of mammogram. What choice of modality? You will go for ultrasound if there is implant, or just mammogram?
Well, implant gonna make a special technique for a mammogram.
Excellent.
Have to be dealt with. I always recommend the patient who's gonna go for the implant, for whatever it is the reason, to have a baseline. So they have to have a special technique. Some of them they need, and most probably they will need an MRI breast to screen them. But still, mammogram is doable with a special technique.
Excellent, great. And what age? Now we agree that the most effective screening method is mammogram, not self-examination. Self-examination is unreliable. What age you recommend to start screening a mammogram for women in Saudi Arabia, particularly?
Well, if you would have asked me about a frank personal opinion, because we don't have the strong data and guideline to say that, I would ask any woman 35 years old to go for that. Definitely the North American guideline, it varies between 40 to 50s, that's varied, but I'm relying only on a personal experience that we do have an earlier breast cancer and a huge breast cancer, so I think we are dealing with a different population.
Excellent. So given your extensive experience, so you recommend that to, recommend earlier screening, because it's more prevalent and more aggressive. Thank you for highlighting that, because always I think that we look at the data, international data, but we have to put it in the context of our, culture, our patient. May they behave differently. That's why we are, asking for more local studies, in order to have guidelines that tailored to our population. You mentioned that fine needle aspiration. Is it biopsy, or they just is it reliable fine needle aspiration, or you need to more take bigger biopsy? We call it core tissue biopsy.
Actually, fine needle aspiration, I'm totally against it in the breast. I think most of the time it's not going to give you a good sample. That means it could be easily misleading. So core tissue biopsy, usually it's done ultrasound guided or some sort of radiologically guided, either a stereotactic, or ultrasound guided, or if they have the MRI guided biopsy, but it's a core tissue biopsy.
Excellent. Doctor, what's the effect, we diagnose breast cancer? What are the stages, of breast cancer?
Well, the most important things, if it's invasive or non-invasive.
Excellent.
So the non-invasive one is basically, it did not penetrate the basement membrane. So to make it easier, basically the cell is abnormal, it's definitely cancerous, but it's just at the very, very beginning. And luckily we just got it at that stage. And that's basically way better result. When it just started getting more aggressive, how aggressive is aggressive? That will make the breast cancer, and that will make the stages. Stages probably depend upon the size, how much it spread to the lymph node, and how much spread outside the breast and the lymph node, the axillary lymph node. If it's spread to the other organ, that make it worse and worse.
Excellent. Very beautiful. And the early stage or cancerous stage or cancer in situ, can you talk more about this? what's the significance if you pick it up at this, early stage?
So the DCIS or the lobar carcinoma in situ, those picking up those changes early on before it's invading the basement membrane, definitely making the prognosis way better. So that's the reason probably, and usually it rarely presented by a visible signs. Okay, it may present like those hidden signs like the nipple discharge, or just picked up during a screening, or picked up during anything else, any other radiological modality, without presence of any sign or symptoms the patient complain. And that's why we advocate for those screening method by mammogram and ultrasound to pick up things very, very early before it's progressed and getting out of control. And as far as things under control, the survival rate, being the chance of live healthy and live for a normal expected life, will be the same. So that's basically the early cancer.
Curable. Okay.
It's pretty much curable.
Excellent. Great. That's why we emphasize the importance of screening programs, because the cancer is curable. Unlike other cancers, if you discover it in early stage, like for example lung cancer, it has no hope, okay, for treatment. Do you think, doctor, that most of our patients you encounter in your clinic or new practice discovered early stage or advanced stage?
It's mixed, but I have to admit, I'm quite surprised how much people are aware of breast cancer. We have a great awareness of breast cancer, and sometimes I feel it's reached up to the anxiety level in our community about an obsession about breast cancer, which is to some extent I do advocate being on the cautious side, given the fact that we are a high-risk culture.
Okay, great. So you are now, seeing the fruits of screening program. So you are, encountering early stage and more cure rate. What decides the modality of treatment, and what are the modalities of treatment for breast cancer?
Thank you for this question. So if it's an early cancer, it's still in situ, before it's becoming advanced and spreading within the breast tissue, surgery usually the mainstay of treatment, followed, depend what type of a surgery, will decide to add on the radiation part or no. And usually in that stage, we'll say usually doesn't go to the lymph node. So sometimes the doctor will just take that sick part and remove it. Sometimes that will be the end of it, surgery, and that will be the end of it. Sometimes we need to supplement it with a little bit of radiation therapy. Probably going to talk about radiation therapy a little bit later. And most of the cases, we don't do anything with the axilla. If anything, we just take sample. But usually if it's in situ, in the very, very early stage, surgery will be it. After that, we'll decide if adding a hormonal therapy, which is a tablet, that will be case by case, and depend if the woman having a family history, if she's premenopausal or postmenopausal, that means she's still having her period or stopped, if she needs those therapy or no. So that will be a discussion case by case.
Excellent.
For the advanced cancer or for the invasive cancer, again, the modality of treatment depends on the stage. On another word, how big and how aggressive and that cancer has been spread. Chemotherapy, surgery, radiation, we either combined, we either choose one modality or other. Pretty much if the cancer still did not spread to outside organ, outside the breast and the axillary lymph node, surgery usually taken parts.
Excellent. Excellent, Doctora. We will elaborate more on the surgery or surgical approach for breast cancer. Excuse me to go for a brief report about breast cancer. To watch more details about this report, please stay with us.
October is Breast Cancer Awareness Month, and while most people are aware of breast cancer, they may be unaware of certain factors which increase the risk of developing the disease. Individuals with a strong family history of breast cancer may choose to receive a gene test to assess these risks. A gene test looks for specific mutations in your BRCA1 or BRCA2 gene A mutation in these genes can be inherited from either your mother or your father. BRCA1 and BRCA2 help control normal cell growth. Mutations in these genes may increase the risk of developing breast cancer. According to the National Cancer Institute, about 12% of women in the general population will develop breast cancer. However, about 45% of women who have inherited a BRCA2 mutation will develop breast cancer, and about 55 to 65% of women with a BRCA1 mutation will develop breast cancer.
Healthy cells are the basic building blocks of all tissue and organs in the body. But when cell DNA, the cell's wiring, is damaged, mutated cells begin to rapidly reproduce without following the pre-wired plan. Aggressive cell growth can form a tumor or mass of tissue that, like each individual cell, does not function as originally intended. These abnormal cells, or group of cells, can progress into the disease known as cancer. Breast cancer usually begins either where the milk is being produced, the lobules, or in the milk ducts. Lobular carcinoma in situ, LCIS, is a precancerous condition that forms and is contained in the lobules. Invasive lobular carcinoma is a type of cancer that develops and breaks through the lobules, with the potential to spread to other areas of the body. Ductal carcinoma in situ, DCIS, is a type of cancer that forms in the milk ducts and is considered non-invasive because it has not spread to any surrounding tissue. If the cancer has spread beyond the milk ducts, it is known as ductal carcinoma. Less frequently, breast cancer can originate in the stromal tissue, the fatty and fibrous connective tissue of the breast. Treating breast cancer as soon as it's discovered is very important. If left untreated, the cancer cells may invade healthy breast tissue or lymph nodes. Once in the lymph system, cancer can spread more easily to other parts of the body.
Once again, welcome back to Elixir of Life. It's my pleasure to welcome my distinguished guest, Dr. Nuha AlSaleh. Welcome back. We continue the same line of discussion. We paused on the surgical treatment of breast cancer, mastectomy versus lumpectomy. Could you continue the same discussion, please?
Absolutely. So in treating a breast cancer, we have to discuss two components: the axilla, because it's related, and the breast. So the breast, to make things easier, either mastectomy is basically removing the whole breast tissue. Then we decide if we're going to reconstruct that tissue or no, and that's a prolonged discussion, or just we're going to remove a part or the disease area.
Excellent.
Sometimes for the axilla, it's either a sentinel lymph node biopsy or axillary dissection. It's basically either taking a sample. If I'm not sure if the disease spread, if I don't have any evidence, either by clinically feeling that or radiologically, that any evidence that the cancer has spread there, what we do during the same surgery, we do take sample based on a special technique, injecting special dye and special material to tell us probably this cancer went to the axilla or no.
Mm-hmm.
That's what we call the sentinel lymph node biopsy. It's simplified, taking a biopsy only from the axillary lymph node.
Beautiful.
Axillary dissection, basically removing the whole lymph node in the armpit.
Mm-hmm. So dissection. So is there a difference between modified or radical mastectomy, or they are basically the same?
Radical mastectomy, it's fallen out of favor. It's kind of historical things. Now people either do a modified radical mastectomy. Now the other things is coming up, the subcutaneous mastectomy or nipple area preserving mastectomy, and all those new techniques came by. How much they save? Are they going to save the nipple areola complex? How much of the skin can I save? And the larger skin they save, they make it easier for our friend in plastic surgery to reconstruct. However, this is a discussion and it's not always been possible. Exactly. So all those techniques available, but it's not feasible for each patient, have to be discussed patient by patient and depend on too many factors. Part of it, the patient factors like the breast size, the body habitus, and all that stuff, and the cancer stage and position.
Excellent. Wonderful. What are the complications of breast cancer surgery, mastectomy or lumpectomy?
First of all, I would like to highlight one thing. Sometimes patient will come to me wanted a wide local excision or a whole mastectomy. I mean, discussion with the patient is important and making a choice is important, but for the wide local, sometimes it's not feasible. It's just not right for that patient. The cancer having too many spots spread all over the breast, where saving the breast is just impossible, or just saving part of the breast is cosmetically basically not a good result. Breast surgery is one of the least painful surgeries, having the least complication probably in terms of, I mean, bleeding could happen, infection could happen, but really is the least painful. I mean, surprisingly, patient would not use any strong narcotics. It would be good with just a regular Panadol, Profen. Surprisingly, if they will use one or two narcotics like the Tylenol 3 or Tramadol. But probably what is the most complication and the most annoying, it's the lymphedema, which is likely going to happen with the axillary dissection.
What do you mean lymphedema? Swelling of the arm?
Yeah, so the lymphedema is the swelling, the persistent, permanent swelling in the arm after removing the whole lymph node. We have to do it sometimes we have to do it in breast surgery. That could be a truly affecting a true morbidity for the patient. It's persisting swelling, persistent pain sometimes. Sometimes, unfortunately, could be bad enough to stop the patient from able to participate in a daily life activity. So this is really an important thing the patient have to know about it. It's common in axillary dissection, but it still could happen in the sentinel lymph node biopsy, although it's very, very rare, like less than 5%. But this is, I think, the most important discussion in the breast surgery.
Excellent, Doctor. How you overcome the lymphedema or swelling? Is there any treatment like stockings we use for the lower extremity?
Well, unfortunately, there's nothing surgically I could do to alter the chances for having this swelling after the surgery. Then we do some techniques to help the patient to deal with this problem. So it's basically supporting. We cannot really cure this problem. So we ask them to do certain physiotherapy, certain exercise, put a certain position, the arm in certain position, use the stocking. That will help them, but all those small techniques just help them get through this problem. But unfortunately, till now, we cannot cure it.
What about the psychological impact of mastectomy? Is it a real problem, or they feel psychological aspect after mastectomy?
Well, definitely, especially for breast women. Breast is an important organ for them. So mastectomy do affect their psychology and affect the self-perception and even the sexuality of the woman. So that's why tons of people came with that concept of the immediate reconstruction.
Okay, that's the next question. Yeah, that about to talk about the reconstruction. Okay.
Yeah.
Do we do reconstructive surgery for all patient after mastectomy, or you have case by case basis?
Well, it ideally should be discussed with every patient. However, it's not always doable for every patient. Reconstruction could happen immediately. That means the woman will have her cancer removed, followed by putting some replacement, some sort of a replacement for this diseased breast on the same spot, so she will wake up with the same image of her body.
During the same surgery?
During the same surgery. And usually women, if it's feasible, it's been reported in the study actually, they do feel much more self-confident, it's a better self-image and all that stuff, but it's not always feasible. The delayed one, that after dealing with the whole cancer, finishing up everything and getting the chemotherapy if needed, the hormonal therapy, being sure that's not going to come back, then they could go that for this type of a surgery later on, usually somewhere between 1 year to 2 years after the surgery. after the mastectomy,
after
which
the
is removing
mastectomy.
the breast.
Beautiful. So is there any types of reconstructive surgery or just one surgery?
No, definitely it's a wide variety. It's a specialty dealt with a plastic surgeon. So we work as a general surgeon with a plastic surgeon to do this type. So either they use the same tissue, so some of them they use the abdominal muscle, they flip it inside and use to give the bulk, or they could use a muscle from the back and they flip it to give that bulk again. They could supplement it with an implant, which is a silicone gel, and put it for that part. And I have to pinpoint something: reconstruction not only with mastectomy. Sometimes we do reconstruction with the wide local excision. Even if we remove that part of the breast, we could still use reconstruction. Either reconstruct with the same tissue of the breast, or just adding implant to that area.
Excellent. Thank you very much, Doctora. Now we are going for the second report. To watch more details, please stay with us. Once again, welcome back to Elixir of Life. Welcome back, my distinguished guest, Dr. Nuha AlSaleh. We will move after, surgical therapy or surgery. What other modalities of treatment?
The three modalities to supplement surgery, if needed: radiation, chemotherapy, and hormonal therapy.
So we talk about chemotherapy.
Yeah.
Next one.
So chemotherapy, it shouldn't be so scary. It's just a medication, help to kill those small cells. I cannot see it by my own eyes. Either could be given before the surgery, or before and after, or just after the surgery, or not given at all. So that should be dealt with as a case by case, depend on which type of cancer that patient have. For radiotherapy, again, it's really depend on if I gonna do removing the whole breast, doing the mastectomy, or the wide local excision. So as a rule of thumb, wide local excision have to be accompanied by the radiotherapy. And it's, to simplify it, I would say to the patient, it's a very specialized light applied on the affected area and kill the invisible things, cells may present there. The hormonal therapy, it's tablet. It's affecting the hormones, which usually stimulate those cancers to grow up. And again, is not for every patient, the age of the patient, she's premenopause or postmenopause, and the type of a cancer will determine if we need to do that. And I have to pinpoint on what they call a biological, which is like the Herceptins, and that given to certain type of a breast cancer. So this is a general rule. Case by case will determine the need of those modalities or no.
So just that breast cancer is not one type, one is not one histological type, there are many types. So, and horses for courses, each kind of cancer that will be treated either by single modality surgery or combined surgery followed by chemo, or it could be surgery, chemo and radiotherapy and versus hormonal therapy. So because just to highlight that there is a taboo, or I would say social stigmata that about breast cancer, it is coined with death. Is it true, doctor? So the cancer is equivalent to death. Do you think that it's valid or?
Absolutely not. Absolutely, I disagree. And I'm talking specifically about our culture in Saudi Arabia. The increased awareness and increased early detection, I see it in my actual clinical practice, telling me that people would have a survival rate, meaning the chances for them to live their life as if they didn't get any cancer, is more than 90% in the early stage cancer. So absolutely not necessarily mean breast cancer equivalent to death.
Excellent.
The survival rate definitely differ with the stages, the earlier is better as a common sense, but you're really doing very well, and we'd like to do better in detecting breast cancer in our community.
Very beautiful. How we monitor a patient after surgery or follow-up, in brief?
So basically what I tell my patient, we'll be friends for the next 5 years. She will be friends with me or with the oncologist or both of us. Mammogram have to be done to either the same breast if we kept it, and the contralateral breast, the other breast. CT scan in certain cases have to be dealt. CT scan is a special X-ray, check the lungs and the abdomen to see if there's any evidence of disease in that area. How frequent? Usually we have a guideline and based on case by case, but usually for the first 5 years, patient will be friends with her doctors.
That's why it's important to build alliance with the patient.
Absolutely.
What are the take-home messages from such important and insightful interview with you, doctor?
Early detection, that means screening. So if I would give one message for each woman here, please do your screening. If you have any concern, please do not hesitate to go and see a doctor. Probably is nothing you are scared about, but to be reassured will ease up your life and ease up your mind. That will be my main take-home message.
Thank you. With that, we are coming to the end. I would like to thank you. I'm really grateful for you. I appreciate you being here. You enlightened us about very important topic, breast cancer, and I hope we answered all the questions. It's really great pleasure and honor with us, and hopefully would like to see you again in our program. Thank you, doctor.
Thank you, Dr.sheef, for giving me this opportunity.
Okay, thank you. Now we are coming to the last segment of our program, Health Benefit. To watch more details, please stay with us. Once again, welcome back to Elixir of Life. Now we are coming to the end of our program. Before I conclude, dear respected viewers, I would like to thank our team for their great work, and I wish you found our episode useful and motivating and enlightening, and I wish to see you again in the next episode. I wish you a pleasant time until next episode. Goodbye. Assalamu alaikum.